I think the potential of polygenic risk scores is that it allows us to identify early in life individuals who are at high risk of particular diseases. And if we're able to do that, we can target interventions in some cases. So for coronary disease, either lifestyle changes or statin, lipid-lowering medications, or in other cases, it can allow us to target screening. Critically, because they're based on common variants, to get the information needed to calculate polygenic risk scores, you just need to run a genotyping array. You don't need to sequence individuals, so it's cheaper by a factor of something like 20-fold. And it's something that starts to be accessible at a population scale. You can do one genotyping array and calculate polygenic risk scores for, say, 20 different diseases. And interestingly, although any one of you is probably not in the top 3% for heart disease, well, the chance that any one of you is 3%, and you're probably not in the top 3% for type 2 diabetes, and if you're a woman, probably not in the top 3% for breast cancer and so on. Across 20 or so diseases, you're likely to be in the top 3% for something. So one way of thinking about this is it allows us as individuals and healthcare systems to work out what are the 2 or 3 diseases at which we happen to be at increased risk because of the common variants we inherit. It's different from traditional clinical genetics in another way. So these scores are risk factors. If you have a high polygenic risk score for coronary disease, it increases your risk of disease in the same way that having a high LDL cholesterol level increases your risk of disease. Neither is determinative, and in each case you can do other things to mitigate the risk. So we should think about polygenic risk scores in that way. They're much less correlated amongst relatives. If you're in the top 1% for polygenic risk score for a particular disease, then the chance that one of your kids or one of your siblings is in the top 1% is 10%. They're at increased risk, but it's nothing like if a woman has a BRCA mutation, then all of her female relatives her first-degree relatives have a 50% chance of carrying the mutation, and it then has a very significant effect. So I'd argue we should think about it much more like medical tests. Doctors of different specialties and in primary care can think about it. We don't need clinical geneticists to be doing polygenic risk scores, and I don't think we need genetic counselling to be feeding it back to individuals. They're useful for risk prediction in all individuals. They perform more powerfully in individuals of some ancestries than others currently. So that's absolutely something that the field should be focused on. It's something that we're focused on in genomics. That'll get addressed in 2 different ways. One of them is improving the algorithms, coming up with cleverer methods that can make use of the data we do have available on other ancestries, and the other one is larger data sets. So I see that as a very significant but short-term effect. The final one is to say that we've put a lot of effort into this within genomics. My background, as many of you will know, in the academic world was statistical genetics. Vincent Plagnol, who leads for us on this area, and his team have got polygenic risk scores for 15 or 20 or so diseases, and in each case they're comparable to, and in most cases better than, those that have been published. I'll just finish by giving you a sense of where this is going into healthcare. That's what we're aiming at. We're aiming at using this in a way that makes a difference to clinical care. So in the UK, there's very strong support from the government, including the guy who went through this experience himself, Matt Hancock, the Secretary of State for Health. There has been a recent announcement of a large cohort in the UK of 5 million people. A key part of the thinking behind that cohort is the idea of getting genetic information through genotyping arrays, calculating polygenic risk scores, feeding that back to the individuals and feeding it into the National Health Service, into the healthcare system. And a number of other parts of the National Health Service who are talking to us about doing polygenic risk scores in primary care in some instances and in some other contexts as well. And we'll be doing the polygenic risk scores in the 5 million cohort, the ADD cohort. We're in discussions with a number of healthcare systems in the US again about early adoption and thinking about piloting this in a number of different ways. We can discuss it a bit more in the question and discussion which follows, but I now think strongly that actually this is the area. I've been working hard for 20 years, as you've heard, trying to use genetics to understand human disease better, common human diseases in particular, with a view to improving the way we develop medications and improving clinical care. I'm absolutely convinced that this is the area where genetics will have its biggest impact on healthcare. It's all the common diseases. It allows us to identify people earlier in life and then to work out how to get the right interventions or lifestyle changes, or how to target screening appropriately.